Thank you, Priya. Thank you, all the participants who are all the medical college faculty from different parts of the country to join us for today's program. As she mentioned, the first part, we will be covering the basics of palliative care. I understand some of you have had initial training in palliative care. So we expect a lot of discussions, questions and answers and learning from each other during the sessions. Today, we'll start with the introduction to palliative care, sharing the ideas on the concepts of palliative care that we practice here and what we want you to all implement in your institution, teach your students in the future. So we have Dr. Sunil. Dr. Sunil is the additional director of Trivandrum Institute of Palliative Sciences. Ours is a WHO collaborating center for training and policy on access to pain relief. Dr. Sunil has done his post-graduation in palliative medicine from the School of Medicine, Cardiff University, UK. He's also a faculty member and expert group member for various palliative care programs across the country. He's also a mentor for a quality improvement program called Equip India program. He has done, he has many publications and written chapters in textbooks, which is used in education in palliative care. He currently heads the education as well as the clinical services in Palliative, which is in Trivandrum. So today we will hear about the introduction to palliative care and we'll touch upon the basics and introduction of pain. And as Sripriya mentioned in the beginning, we really want all the sessions to be very interactive. Please feel free to ask questions, put it in the chat if you don't want to or cannot unmute, and keep your videos on as much as possible because we all know that how online training we pay attention. So we want you to be with us for another 90 minutes. So please switch on your videos throughout the session. Sir, it's over to you, sir.
Thank you, Sridevi and Sripriya. Good afternoon, everybody. So I will share my presentation. Okay, so I'm sure many of you might be working in palliative care or somehow have come across some aspects of palliative care. But this session is mainly to introduce you to the real ideas of palliative care and very basics of pain. Okay. So here we have a patient. You can see this patient. So this patient is a 50-year-old man who is diagnosed with carcinoma of the penis. And he underwent surgery and radiotherapy for the same 2 years back. But then he had a recurrence. He had very severe pain. And then he went to his treating oncologist. And the cancer was in very advanced stages. And there was nothing more they can do at that stage for curing or palliating the problems of this patient. So his main problem is severe pain on both legs and scrotum. He described it as like a burning pain and as well as throbbing. And he scores 10 by 10 on a scale of 0 to 10, where 10 means worst imaginable pain. You might have seen the wounds on legs. There are multiple ulcers on his legs, and both legs are edematous, as well as you can see the lower abdomen as well as edematous. So he actually was talking about his pain, and he says it is always 10 by 10 and unable to sleep, and he is not eating much because of pain, because the pain was so terrible. He can't do anything. And his wife then adds that at night he walks around the house nakedly after taking all the clothes. So we asked him why only at night. So the wife told that at night, there is nobody else to see this. He is walking around house nakedly. But otherwise, in the morning, there would be his children and the neighbors. So, why he is walking like this? He says, whenever I walk like this, I get some relief. But even then, my pain score is 10 by 10. So, any of you have had patients like this? Any of you have experience with this type of pain? Anybody? You can unmute
Yes,
and
sir. I
speak.
have.
Yeah,
Yes, sir. I have encountered.
Dr. Manoj, you can share your experience.
Sir, I've seen one patient of CA base of tongue that has burning sensation and throbbing and type of pain like this only, and it was of mixed type, nociceptive and neuropathic both.
Mm.
So we started with and his NRS was also 8 to 9 by 10.
Mm.
So according to WHO grading, we started with the tab morphine and capsule gabapentin,
Mm.
and his pain relief. He got some pain relief after 5 to 7 days.
Okay. Yeah, thank you for sharing that, Dr. Manoj. But this patient, you can see the severity. Somebody who walks around his house nakedly. So you can assume how severe his pain would be. And he was from actually from a biggest city in Kerala, and he consulted many doctors for his pain, but there were various medications that he has taken, but he didn't have any pain relief. So he was suffering like anything. So, regarding his family, this patient was working as a security guard in a jewelry shop, and his wife was an attendant in a school, and he has two children. Both are studying, and his house is just like a small hut. We cannot say it is a house. So that was very pathetic. So we actually saw this patient during one of our home visit. So we go and visit the patients at their home. So that's when we met this patient. So what would you do for this patient? He has such a severe pain, and when he takes out the cloth, he gets some pain relief. What would you call it? When the clothes, the even the touch of fabrics produces pain, what would you call?
Neuropathic pain.
Neuropathic pain,
Neuropathic.
allodynia and hypergesicula.
Yeah, it's allodynia because
Or allopathic pain. Allodynia.
yeah. So usually the touch of fabrics does not cause pain, isn't it? So the stimulus usually does not cause pain. When it produces pain, is called as allodynia. So um, when he takes out clothes, he gets some pain relief. That indicates that he has allodynia. Okay. So how are you going to manage this patient? Can anybody tell me?
Is it audible?
Yes, yes.
Can we start amitriptyline or
Yes. We can start him on amitriptyline.
amitriptyline?
Yes. Thank you. Anybody else?
Initially, we will do peripheral Doppler for arterial blood vessels.
Doppler for arterial insufficiency.
Yes, sir.
Okay, thank you. Any other response?
So as it is a neuropathic pain, we can start with the tricyclic antidepressants or anticonvulsants like gabapentin, pregabalin, and we can think of some intervention also because patient is having so much pain. So intervention is necessary in as per of WHO criteria also.
Okay, thank you, Dr. Manoj and everybody else. So this patient already received gabapentin, amitriptyline, imipramine, all those anti-neuropathic pain agents, and he was receiving 5 milligram of morphine 4 hourly. And I would say he was on optimal doses of anti-neuropathic pain agents also. So as Dr. Manoj said us, maybe some interventional pain management would be better because he is in severe suffering. Okay. And this patient actually, we admitted him and gave him epidural analgesia. Okay. But even then, he did not had satisfactory pain relief, and his pain was actually increasing even after epidural analgesia, even with the bolus doses. And we confirmed that the epidural catheter is in the epidural space. So at last, by seeing the suffering of the patient, his wife actually requested us, please kill my husband. I cannot see this anymore. We were suffering for long time, and I cannot bear this anymore. Please kill him. And now both of us are here. There is nobody else, so you can inject something and kill him, and nobody else would know about this. So that was the wife's request. Okay, so what are the suffering this patient and family is facing? He has physical suffering, isn't it? He's in severe pain. He's unable to sleep. He's unable to eat. Has multiple ulcers on the leg. Has edema. So he has physical issues or physical suffering. Then he has psychological issues. Yeah, I can see Dr. Pradiksha says physical and mental. Yeah, psychological suffering because we are unable to relieve his pain, and that itself, even though it is physical thing, but the pain can produce lot of emotions, isn't it? And yeah, spiritual. Dr. Abraham says spiritual. Yes. So psychological, social, and financial, isn't it? Because both of them were unable to go for any job, and how would they get money for a daily living? And they don't want anybody to come to their home because he is suffering, and they don't want anybody to see this. And probably he is naked also every time. So there is social isolation as well as financial suffering. And as you told, spiritually also he is suffering because why God did this to me. I took so many medications for pain, but still I'm not having any relief. So he has suffering in all these components. So what would you do for this patient to treat or to manage his problems?
Epidural morphine.
Yeah, epidural morphine. Yeah, actually we gave him epidural local anesthetic with morphine. Yeah, that's one thing. Yes. Intrathecal chemical neurolysis. Yeah, intrathecal neurolysis. Anything else? Anything else we need to do this for patient? Yeah, lumbar sympathectomy. Okay,
Hello.
counseling. Yeah. Dr. Rajesh, you are muted. You can unmute and speak.
Hello.
Yes, sir.
What about the penile block with sulcerkin, bupivacaine with fentanyl
Okay.
for the thing acute pain relief?
Okay, thank you. Thank you everybody for your suggestions. So most probably this patient received many things, many medications, including injection morphine, then local anesthetic, even local anesthetic infiltration locally, epidural analgesia with the bolus doses, and probably his pain now has become centralized. So that might be the reason why he is not getting pain relief. Okay, thank you all for your suggestion. So that's one thing. Yeah, we have to manage pain. Yes, and somebody else told that we have to give psychosocial support. Yeah, that's very, very important. Counseling the patient and his wife regarding the situation. Yeah, they are very much aware of the situation of the patient. He has a very advanced malignancy, and probably his um, life is limited. Yes, all those need to be done. And what about his children? How are they eating? Are they going to school? We need to do anything for them? Okay, so we talked about the suffering of this patient in these aspects: physical, psychological, social, financial, and spiritual. So we have to actually manage all these aspects of suffering. Okay, and we may not be able to solve all the problems, but still we have to try our best to relieve his suffering. And so I'm coming to the definition of World Health Organization regarding palliative care, and this is a very, very long definition. Maybe it is maybe kilometers length, but please concentrate on this important points. What does palliative care do? It improves the quality of life of patients, not only patients, but also of their families. How are you going to improve the quality of life of patient and family? Then you have to look into the, you have to treat the pain and other problems, physical problems, psychosocial problems, and spiritual problems. Okay, so palliative care is an approach that improves the quality of life of patients and their families. The family is included in palliative care by treating their suffering, by addressing their physical, psychological, social, financial, and spiritual issues. Okay. So this is the 2002 definition, or the present definition of WHO. But I just want you to take you to another definition of palliative care from 1990 by WHO, which says palliative care is the active total care of the person whose disease is no longer responsive to curative treatment. So this was the previous definition. Palliative care will start when there is no curative treatment or when the curative treatment ends. Okay. So, but then in 2002, it went a step ahead, and it said that according to 2002 definition, it says it is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy, radiation therapy. So palliative care can be given along with other curative therapies. That's what 2002 definition says. Okay, but so I'm telling about the evolution of palliative care, and in 1990, when disease is no longer responsive to curative treatment, in 2002, it is applicable early in the course of illness in conjunction with other therapies. And in 2017, this is not a WHO definition, but this is a definition by Lancet commissioners. So Lancet Commission, they appointed a few commissioners in 2017 on palliative care, and they came up with this definition. Palliative care should be focused on relieving serious health-related suffering that is associated with life-limiting or life-threatening conditions or end of life. So they say palliative care can be given to any patients with serious health-related suffering. So you can see actually the what are the categories included in serious health-related suffering. You can see on the left hand, it says patients with end of life who have physical or psychological or social or spiritual issues need to be included in palliative care. Any chronic or acute life-threatening or life-limiting diseases, ill health, or injury, that is also included in palliative care. And even if that is not associated with life-threatening or life-limiting health condition, that those patients can also be provided with palliative care. So actually this, according to this, the concept of serious health-related suffering, it covers a lot of patients, a lot of maybe I would say almost all the patients under this serious health-related suffering. Okay, but we may not be able to get this into practical aspect because even now we know that in India only less than 4% of the needy are getting palliative care. So, but this is for you to understand what is happening in the world. Okay. So this patient has physical, psychological, social, and financial and spiritual suffering together. So this is known as total pain concept. Okay. So total pain concept, this is put forward by the pioneer of palliative care or founder of modern hospice movement, who is Dame Cicely Saunders. And in 1967, she actually started this hospice, which is known as St. Christopher's Hospice in UK. Okay, so she is the founder of modern hospice care. And I just want you to listen to this video and please note what all points you think is important from this video. Okay, thank you for watching this video. And can any of you tell me, are there any points that stuck your mind?
individual approach.
Sorry, Dr. Vijay, we couldn't hear you.
Am I audible now?
Yes, now audible.
I'm saying individualized approach makes a difference is what they are trying to convey.
Okay, thank you. Yeah, that's very important, isn't it? Yeah.
To me, I think what was really the sentence that had a lot of impact for me was not just talking about the patient, but talking to the patient. I think we forget a lot of the times when we kind of treat the patient as an object in the room and we talk about them around them as opposed to considering them as a human.
Yeah, thank you, Dr. Sudha, for bringing that point. And I think in the beginning, the son was talking about, in a traditional sense, I can say that our mother got good medical treatment, but what was lacking was medical care. So, what do you think? Is there a difference between medical treatment and medical care? And he continues to say that all the doctors were seeing her as a case, not as a person. So is there a difference between case and person? So I just want you to understand this. Palliative care, there may be many types of approaches. So it may be person-oriented approach, it may be illness-oriented approach, it may be case-oriented approach, it may be disease-oriented approach, and it may be medical treatment-oriented approach, maybe medical care approach. So palliative care concentrate on person-oriented approach or illness-oriented approach. Okay, illness and disease, all of you would know the difference. For example, if a patient is having squamous cell carcinoma of the cheek with maggots in the wound, foul smell, pain, patient is has fear about death. The disease-oriented approach would look only into the squamous cell carcinoma. It does not look into the person. But if somebody looks with a disease along with her suffering, the maggots, her anxiety, foul smell, if all that is taken into consideration, then it is an illness-oriented approach. So the palliative care is concentrating on person-oriented or illness-oriented approach. Okay. So now I am moving on to, with that, I am leaving palliative care and little bit of pain now. So this is the definition of pain by IASP. It is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damages. You know, it is an unpleasant sensation. Pain is not a pleasant sensation, but they say it is also an emotional experience. So all of us know that emotions are going to affect pain. And the experience, every time you have a pain, the memory or it is stored in your brain, and whenever you have pain next time, you are going to compare with that. So it is also an experience. So it is an unpleasant sensory and emotional experience associated with actual tissue damage. So when there is an injury, definitely that is an actual tissue damage that is going to produce pain or potential tissue damage. So potential tissue damage is something which is not producing damage to the tissues at present, but if that stimulus is prolonged, that is going to produce damage. For example, a patient with peripheral vascular disease, his main complaint would be pain, but in the beginning there is no tissue damage. But if maybe after 1 or 2 years, the patient may get ischemia and gangrene. So that is the potential tissue damage. Okay, or described in terms of such damages. That means if any person comes to you and describe you that I have pain on my hand, it is burning, it was there for the last 2 years, and I took many medication, there is no relief. But on your examination and investigation, and from history also, you couldn't find out anything that is contributing to pain. but still you have to believe the patient. That is what is written in the words described in terms of such damages. Okay. But this definition has recently changed in 2020. And you can see many patients who are unable to describe the pain, isn't it? Because they have communication problems. Neonates may not be able to describe it. There are many other patients who is unable to describe it. That doesn't mean that this patient does not have pain. So they have taken it out and has come up with a new definition. And a little bit of physiology about pain. So you know this is a cross section of the spinal cord, and you know that there is something called as dorsal root ganglion near to the spinal cord. So this dorsal root ganglion has a peripheral process which ends in free nerve ending. So this is the free nerve ending, and the central process, it synapses with the dorsal horn of spinal cord. Okay. So these free nerve endings are known as nociceptors or pain receptors. So in our body, the free nerve endings are the receptors for pain, which is known as nociceptors. And what are the types of receptors in the tissues? There are many types, A, delta, and C. These are the pain receptors which carries pain, A, delta, and C. And in addition, there are some silent nociceptors. That means they are silent most of the time, but they can be activated when there is inflammation. Okay, so that is known as silent nociceptors. And then there is A beta fibers, but A beta fibers are not connected with pain. They carries the sensation of touch. So basically, A, delta, and C are the receptors or nociceptors which carries pain. A delta for acute pain and C for the pain which for the latent phase. And the A, delta, and C fibers, they terminate in the lamina 1 and 2 of dorsal horn of spinal cord, whereas A beta fibers, they terminate in lamina 3, 4, and 5. This is important because in long-term pain or chronic pain, there are some changes happening in this dorsal horn. Okay. And you can see this is the pain pathway. The peripheral nerve, which from the free nerve endings, then the peripheral nerve, then it synapses in the dorsal horn of spinal cord, then it crosses to opposite side and ascends as lateral spinothalamic tract, which then synapses in thalamus, and from the thalamus, there are pain projection fibers to somatosensory area of the cortex, as well as to limbic system, amygdala, and you know that is connected with emotions and affective dimensions of pain. So that's why emotions also affect pain. And this is what happens in when there is an injury. Okay, so there are 4 steps which are transduction, transmission, modulation, and perception. Nociception means it is the it conveys the information that there is an injury that happened somewhere in the body to the brain. Okay, so it is just conveying information from the periphery to the brain. And nociception and pain are different things. Nociception occurs at the level of nerve, whereas pain is the experience for the patient. So what is transduction? You can see when there is an injury, at the site, there are a lot of chemical mediators released. And this mediators together is known as inflammatory mediators or inflammatory soup. And they contains lot of chemical substances, and most important chemical substance is prostaglandins. In addition, there are bradykinin, serotonin, substance P, hydrogen ion, potassium ions, all these will stimulate the nerve endings. You can see the nerve ending, and that will, these chemicals, once prostaglandin is acted on the free nerve endings, then all the other chemical substances will stimulate the nerve endings, and this will reduce the pain threshold. And this is known as sensitization of peripheral nerves or free nerve endings. And then this will produce depolarization, and this impulse, okay, this because of this depolarization, and impulse will be formed. So this is known as transduction. Okay, and then there is transmission. So from the, you know, from the free nerve endings, the information will be going to the brain through spinal cord, thalamus. So that is transmission. And there is then something known as modulation happens. Modulation means it is modification of pain impulse. So how a pain impulse is modified in our body? There are a few mechanisms, and one of them being descending pain inhibiting system. So this is a pain inhibiting system which works in our body, and this descends down from midbrain, medulla, and pons. And you can see the main neurotransmitters involved in the descending pain inhibiting system is serotonin and noradrenaline, which descends down to dorsal horn of spinal cord, and it prevents the transmission of impulse from the dorsal horn of spinal cord to lateral spinothalamic tract. In addition to descending pain inhibiting system, there is something called endogenous opioids. So there are opioids which are produced in our body, and endogenous opioids examples are endorphins and enkephalins. So they also act on various parts of the nervous system, thereby it reduces the pain. Okay, so these are descending pain inhibiting system and endogenous opioids. Okay, so then comes perception. Perception means it is the conscious experience of pain. So this happens when the impulse reaches the somatosensory area of the cortex. You can feel the pain when the impulse reaches the thalamus, but it will not have the quality of the pain, or it may not be able to describe all the qualities, and may not be able to localize the pain. But when it reaches the somatosensory area, then only the patient will be able to describe what is the quality, and all the things about pain would be the person can describe only when it reaches somatosensory area of the cortex. And the pain can be divided mainly into two types. Whenever there is a stimulus which stimulates the free nerve endings or nociceptors, that is known as nociceptive pain. And the nociceptors are widely distributed in the skin, muscles, and bones. Okay. And if pain is due to stimulation of the peripheral nerve, spinal cord, or brain, that is known as neuropathic pain. So pain is broadly divided into nociceptive pain and neuropathic pain. If a person has a small injury on the finger by a knife, what type of pain would it be?
Nociceptive, sir.
Yeah, thank you. Nociceptive. Suppose a person has gives you a history of herpes zoster, and he complains of pain at the level of nipple, which radiates from the front to the back. What type of pain it would be?
Neuropathic.
Yeah, it would be neuropathic. Person has a fracture of both bones of the leg. What type of pain would it be mainly?
Nociceptive.
Yeah, nociceptive. Because there are the nociceptors are widely distributed in skin, muscles, and bones. Okay. And IVDP, intervertebral disc prolapse. Patient complains of shooting pain from the back to the leg. That would be neuropathic.
Neuropathic.
Yeah. Thank you. So, pain is broadly divided into nociceptive and neuropathic pain. Okay. And nociceptive pain can again be divided into somatic and visceral. Somatic means it arises from the external parts of the body, whereas visceral means the pain which arises from inside the viscera, inside abdomen and chest. So nociceptive, it can be somatic nociceptive pain or visceral nociceptive pain. Okay, and when we evaluate this patient's pain, we need to get a detailed history about the patient, about the comorbidities. You know the importance. Suppose the patient describes about burning pain on both foot, and he also gives a history of diabetes mellitus for last 25 years. So probably it might be diabetic peripheral neuropathy. And you know, there are many drugs, especially chemotherapeutic agents, which can produce peripheral neuropathy. And then you have to ask specific questions related to pain. Then you have to explore other symptoms and psychosocial and spiritual suffering, because you know that this psychosocial and spiritual suffering is going to influence the pain. So it is very important whenever you treat the pain, you have to explore the psychosocial and spiritual aspect of the patient. Then you have to examine the patient and investigate. So these are the steps involved in the pain evaluation. And so I think this would be the most important thing in pain assessment. You have to always consider total pain of the patient while you evaluate and manage the patient. So I think I will stop here and yeah.
But how can we assess suffering? You will discuss that later.
Okay. Okay, suffering is something which we may not be able to quantify, but we can ask them which are the what all problems they face, and if we are able to manage those things and ask them how is your suffering, and the only way to assess and whether we are able to reduce their suffering only by asking to the patient. There is no other measurement that is possible.
Thank you. Thank you. Thank you.
Okay, PHQ-9 questionnaire is not for suffering, isn't it? It is not for suffering. Anybody else has any comments or your experience? If anybody has any comments or anything to say, please. You can unmute and speak.
Any questions or any thoughts, insights? We do understand some of you might be busy winding up your day's work at your institution, but still, we would request everyone to be as interactive as possible because the faculty development program, particularly, we wish that whatever we provide you should reach thousands of medical students out there whom we could not reach in person directly. So, we want each one of you to be our ambassadors, to be the ambassadors of pain-free life in your institution. So we do request everyone to clear whatever doubts you're having and whatever insights you wish to share without any assistance.
Actually, you are the people we are looking for because you would be able to influence a lot of medical students who are going to be specialists and super specialists. And if you talk to them and um, get to them or give your knowledge, then that would be very great.
I would just like to make a comment here. As a clinician, it's really difficult to find the time to assess total pain. I mean, I have, 10, 15 minutes with each patient, and I understand that we are supposed to do this, but maybe one of the things that I'm constantly under stress is not having the time to spend with the patient to assess spiritual, social, and psychological pain of the patient. And if you can help a little bit with that, would appreciate that.
Thank you, Dr. Sudha. And I think if you have a team, that's the importance of team. Team means together achieves, together everyone achieves more. So if in your team, if you have a nurse, social worker, or somebody, even if a volunteer, so I'm sure we have a lot of volunteers, but as medical colleges, you may not have seen volunteers in healthcare system, but we use a lot of volunteers. So once they see the patient, a nurse, they can just assess the patient. They can actually be taught how to ask about psychological issues, social issues, spiritual issues. And once they assess, you can just come and see the patient so that you need not spend too much time for each patient. So I think that would be one of the method by which you can save time. But if you are alone, then that is going to be a problem. But even then, suppose if you have 10 patients, then you have to prioritize. Every patient, you don't need equal amount of time. So prioritize which patient would need more time and then talk to them. So these are the two things which I think would be practical.
Thank you so much.
Dr. Sri?
Yes, Shipriya.
Sir has used all his slides, so and nobody is interacting.
Maybe I can ask how many of you have, have been doing palliative care, or is it something very new to your practice? That would be very interesting to know. You can type it in the chat. Either you have a previous experience in palliative care, or it's the first time that you are hearing what palliative care is. I can see one response from Dr. Shilpa that it's a very new concept. Tribhavani, yes. That's very interesting actually. Right? Because We know that as per the new curriculum, there are a lot of modules which relates directly to palliative care. But I understand many places you don't have palliative care services. And we estimate that only 40 institutions in the country has any palliative care services. So you are all in the dark how to teach the students, because unless we know or we have seen or we are providing the services, we may not be able to tell students. Yes, Dr. Manoj is telling that he is in pain management and you see cancer patients. Dr. Manoj, a question to you from that. So, do you think that you should extend your pain management services to patients other than cancer? I mean, just what is your say in that? You might have chosen to work in cancer pain, maybe due to particular reasons, but I'm just asking, do you think you should extend your services to non-cancer patients also? Thank you, Dr. Abraham, for that. May I know from which institution you are from?
Good afternoon, ma'am. I'm from CNC Ludhiana.
Okay, yeah. So we know that there is a fully functioning palliative care there. Thank you for that information. Anyone else? I can see someone mentioning that there is a practice. I'm practicing OP. Yeah, thank you, Dr. Ruchi, for that. I'm glad that you have clearly said pain management, yes, palliation, no experience. Because when people come for training in pain management, they generally see that we are going to talk about a lot of interventions, but maybe it's a part of the whole palliative care that they can understand. Thank you, Dr. Shika, pain physician looking after palliation. I mean, I just asked this question to understand that, as I said in the beginning, like, how are we going to teach students when there is less of palliative care in the institution and in the country, right? We can say, we can share all the textbooks with you, some PowerPoints, but again, you won't be able to show, like, most of the time students learn from modeling. They see what you do. And if they see that patient is screaming in pain and there is no pain management or conversation or end of life care being given, they don't find the importance of it, or they may not be able to understand why this is being actually taught in the medical textbooks. And I'm quite surprised by the silence of this group. But I'm glad that there are a lot of chats at least. So
Actually, can I talk?
sure, yes, please.
NMC has done a good thing. It has introduced palliative care. I think the only difference what it has made is it has put a different subject under different entity, palliative care. Directly or indirectly, we have all been practicing palliative care to some extent, although it has been highlighted in recent years. Palliation has been highlighted in recent years. And it may not have been practiced as a separate specialty, but of course, we have been talking to patients, maybe cancer patients or patients who are chronically sick in ICUs, or when we are dealing with such patients in rounds. So looking after their emotional aspect and about their spiritual aspects. And again, it depends on the individual doctor who is dealing with such patients, how good you are at conversing with the patient, how much time you actually want to spend. So these things cannot be taught as a textbook. You can highlight these facts. They are a part of treatment of the patient, but it has to come. Communication skill is something which exists within the patient, within the person as per se. So it can't be taught. It can just be highlighted. Okay, this also has an impact on the patient. So that is what is, and nobody can develop this communication skill at a means after at a later age. Yes, you can understand. You can just we can again. I just said we can highlight the significance of all these things. You can't teach somebody to communicate.
Shripriya, am I audible?
Yeah.
Yes, ma'am.
Sorry. Thank you, Dr. Shika. You have very well articulated what I've been trying to say after this comment. Palliative care, yes, we hope or we want every medical teacher or every medical professional to integrate, as you rightly said. You may not be practicing as a palliative care specialist in your hospital. You will be in general medicine, but you will be applying the principles of good communication, or symptom management, or end of life care in your own practice. That is the best way to go about it. But again, that is the challenge, where many of the places palliative care is something very, very new, not heard, or people might have heard it as very different, like a cancer or end of life care. So unless we make it very clear what it means and how it can be applied along the course of many life limiting illness across specialities, we won't be able to make the concepts very effective to students. Thank you so much for articulating that. And you rightly said that it can be integrated into any specialty, any practice that you are doing in your institution. Thank you, Dr. Shika.
Thank you so much.
Thank you, Dr. Krishna, Divya. I mean, everyone knows that about this specialty, maybe heard of, but probably the concepts may not be clear or still following the old concepts. So in this coming days, we will be having a lot of discussions on what it means in the current scenario in the country, and how to teach, how all we can integrate that into undergraduate teaching.
And another good thing is that even for the chronic patients, we can use it as something which I never thought of. I was always under the impression that it is for carcinoma patients or for end of life. Seeing your write-up which you had sent, now I got an insight that for paraplegic patients and other patients also we can use this palliation. So that was something which was new to me. Per se, ma'am is right that we also counsel the patients and we do it on day-to-day basis in ICU. But our concept of palliation was that maybe it is for the end of life care. But from the write-up, what I understood, even for some patients who are suffering from paraplegia, who feel that socially they are ostracized, we can help them out also through palliation. Thank you.
I would like to comment on something that Dr. Shika had mentioned about about how we, each individual doctor chooses based upon their own personality or their own experience about how they deal with the patient in the ICU or in the end of life. But I feel that that experience is very inconsistent for the patient, depending on the doctor that is taking care of them. So whereas in other specialties, such as, let's say, heart failure, it's a very standardized care, right? Every doctor knows how you're supposed to take care of that particular heart failure situation. Whereas when it comes to palliative care, I feel like unless we have a very formal way of training physicians right from the very beginning, then you don't get that consistency. Because some doctor with a good heart and with maybe a natural tendency to be nurturing may be very good to a patient in the ICU and provide that type of emotional support and psychological support that they need. But another doctor may not, if they were not given that formal education as part of standard of care when treating a patient.
Thank you, Sudha, for your comment.
The palliative care actually started as something previously, very in the beginning days. Maybe it was restricted for cancer. And if you look at palliative care centers across India, many of the palliative care centers provides palliative care only for cancer. But as you rightly told, the suffering, it is not only for the cancer. And you might have seen many other patients who are even more suffering than cancer. And actually, there is a systematic review which compared, I think, about 10 non-cancer diseases. And they found out that the suffering in those diseases, I think HIV, COPD, motor neuron disease, and so many other diseases. And they found out that the suffering in those patients, they are as equal to that with those with cancer. So the concept of palliative care or the principles of palliative care is actually applicable to non-cancer diseases also. If we take our statistics, only 40% of our patients are having cancer, and 60% or 50 to 55% of patients are having non-cancer diseases which requires palliative care.
I'd just like to share my own personal experience here about cancer versus non-cancer patient. I went through this with my mother who had interstitial lung disease in Tamil Nadu. And this was something we found at every hospital and every palliative care center, unfortunately, was that your mother doesn't have cancer. So we cannot provide palliative services, or your mother does not have cancer pain, so we cannot provide morphine. So unfortunately, that was a very difficult thing to take. So I hope, that will change with courses like this.
Thank you. Thank you for sharing your personal experience with that. If there are no more questions or comments, maybe we can wind up today's session, Dr. Sunil.
Yeah, we can.
Thank you, everyone. Tomorrow we will be having, we'll be touching upon one session on pain. We have more sessions on pain management. I understand some of you practice pain management in your own setting. So hopefully we'll be having a lot of ideas and sharing tomorrow's session. Thank you so much for being a part of this program. Shripriya.
Thank you, Dr. Sunil. We know that you have extensive works to do, but still you managed and found out time to join us. Thank you so much for that. Thank you everyone for joining in. And we do sincerely hope that by the end of these 12 sessions, we will have a battalion, a team of qualified faculty members who are ready to go out into the real world and teach the medical students the importance of palliative medicine. So with the promise that we'll be meeting again tomorrow with another interesting topic and another eminent faculty. This is Shripriya along with Dr. Sunil Kumar and Dr. Sridevi Warrior signing off from the KIPSECO Hub. See you in the next session tomorrow. Till then, everyone take care. Bye-bye.
Do we need to mark the attendance?
No, ma'am, no. The attendance will be fetched
Thank you
automatically
so
and marked.
Okay,
Shripriya,
thank you so much.
one quick question, Shripriya. You said you had sent the pre-session evaluation, and where is that via email or is it in the Echo?
It was shared in the WhatsApp group. I will share it once again for those who joined late. So
Okay,
as
thank
some
you.
of the members were joined late in the WhatsApp group, so I'll be sharing it again in the WhatsApp group for benefit of everybody.
Thank you so much.
Thank you so much. Thank you so much.